Ma'am, shall we start?
Good evening, ma'am.
Hi, good evening. Hello,
Hello.
nice to have you. How many will be there? I think 49 join now.
Yeah, I think around 100 will be there, ma'am.
Okay. It's getting recorded?
Yeah, it's getting recorded, but it won't be published in the public
Okay.
domain.
And what group of participants? All postgraduates or faculties?
Yeah, mainly it is postgraduates, madam, from the Department of Pediatrics. It's not only from our college, from other colleges as well.
Oh, okay.
As the CME is having embryology classes as well,
Okay.
so gynec postgraduates are also there.
So how
Maybe
were the previous sessions going on? It went well.
good. Yeah, it went well. Yesterday, it was Santosh Kumar's session.
Oh, he's my teacher.
Yeah, he dealt with workup in a GDD case.
Okay. And what sort of it was an interactive session, wasn't it?
Hmm. Yeah. Then embryology is going on. Totally, there are 6 sessions, 3 are over.
Okay.
Then pharmacogenomics was there from Rajiv Gandhi Institute. Moinak sir was dealing with that.
I think I saw that your program schedule.
Yeah.
It takes
So,
5 or 6 classes more, isn't it? Including
yeah.
embryo.
Embryology reached till 8th week. Now the remaining is there.
I saw Government Ayurveda College Kannur presenting.
Yeah, we don't have this G Suite here, ma'am, to accommodate 250%. So I borrowed the G Suite from Kannur College. I was working there
Uh-huh.
prior, so it could accommodate 250 like other members and also include their staff in that. Out of this, above this 250, they can host their staff as well.
So this forum exceeds about 100, more than 100, right?
Yeah, this will come around 100. Otherwise, that other platforms they can't accommodate more than 100. It's 100 is a strict bar over there. So this we have the liberty up till 250. Though 250 won't be there, but liberty is there to accommodate more. Only thing is that, ma'am, in Gmeet, when we are sharing the slide, we have to share the entire screen.
Okay, you mean that full screen?
Yeah, full screen sharing should be there. Then we should, if we are sharing the window, we can't make it in that full form.
Okay.
Slide share won't be possible. That's the only restriction here.
I think, can I check the slide sharing now because we have time?
Sure, sure. We can check for that.
Ma'am, are you able to share?
No, I'm just trying.
Okay, ma'am.
Yeah, now it is visible, ma'am.
Okay. Can you see the entire screen now?
Yeah, now it's perfect.
Okay.
Entire screen. Shall we start?
Yeah.
Good afternoon, everyone. It's a privilege to welcome you all to the enlightening session of our CMA series, Srishti on genetics and embryology. Today, we have the honor of hearing from our expert in the field, Dr. Vinitha A O, a distinguished pediatrician and genetic diagnostics specialist. Dr. Vinitha holds an MBBS, a diploma in child health, and a diplomate in national board in pediatrics. Further enhancing her expertise, she has completed a fellowship in genetic diagnosis awarded by Government of India. She currently serves as an assistant professor in Department of Pediatrics at SAT Government Medical College, Thiruvananthapuram, where she plays a pivotal role in both clinical care and academic mentorship. Her dedication in pediatric health, along with her specialized knowledge in genetic diagnosis, make her a valuable asset to the medical community. Today, we are fortunate to have Dr. Vinitha with us to share her insight and expertise. Please join me in welcoming Dr. Vinitha A O.
Good evening, all. Am I audible?
Yes, Miss. Yes.
Yeah. Thank you very much for the kind introduction. I too feel privileged to be in the middle of a group of scholars who are eager to discuss the genetics. And today we'll have a session on approach to dysmorphic child. Uh, Before going to the topic, let me just ask you how far you are dealing with dysmorphism cases. Could some of you, is it okay to answer some of you? Or do you really daily, I mean, on routine basis, are you handling these kind of cases? Hello?
Sure, you may ask, ma'am.
Ah, yes, Miss. We
No,
use
I understood that so many postgraduates are here, so that's why.
yes.
Okay, that's it's so good. Such a good news to know that you all people are also dealing with such cases. So today, I think this in this session we'll just see how we are going to approach a case of dysmorphism. Okay. So my outline of presentation will be about the developmental process and what is dysmorphology. Then the types of birth defects, patterns of birth defects, and finally, approach to dysmorphic child in the headings. One is history, physical examination, investigations, management, and finally, last but not the least, genetic counseling. I hope it is well audible, right? Because I cannot see anyone.
Yes,
That's
miss. Yes,
okay.
miss.
If there is something wrong, please let me know. Okay.
Oh, okay, miss. Sure.
Okay. So the first thing before dealing with an abnormality is always a normal development, how the child develops. So that's very important. But I cannot, due to time constraints, I cannot deal with all the developmental steps in the child. So, but as an introduction, I can say it's a complex, coordinated process which occurs with multiplication, differentiation, and organization of tissues to organ systems. So it takes place with the help of or with the interaction of genetic and environmental factors. I meant both genetic and environmental factors have a role in development of an individual. And of course, on the genetic side, you need gene expression in various organs at various stages of embryogenesis. Again, I understood that you've got a separate session on embryology and you will be dealing the rest of that there. So major defects in very early stages of embryogenesis may not be compatible with life and it leads to spontaneous abortions. And knowledge of this is very important because you may be dealing with such cases, fetal loss like that when you take the history. So that's why I added that point. So now going to dysmorphology. The word per se, dysmorphology, actually is derived from the Greek word meaning dysmorphia, meaning abnormal shape. You know, as you know, that dys means something abnormal. Morphology means something related to morphology, that's the structure. So it's ultimately abnormalities of body structure that originates before birth, and the term was coined by Dr. David W. Smith. And in this context, you should all know that what is congenital? Congenital means something which is present since birth. So any defect which had occurred during the intrauterine life and that had been present at birth, then you call it congenital. And of course, you have to know what is this malformation. That is, if it is major malformation, I'll explain that in the subsequent slides. About 3% neonates are born with one major malformation. For example, like a congenital heart disease or a ventricular septal defect, something like that. So about 3% of newborns are affected that way. So see that magnitude of the problem. So that's the importance of knowing all these dysmorphology things. Then about 0.7% of neonates, again, they have multiple malformations. That's again another problem in the newborns. So now let us see what are the types of defects. One major, I told you, major means if left untreated, it will lead to significant impairment of the function of the organ, leading to mortality and morbidity. So now you understood what's the importance of this major anomaly. And minor means usually it may be of cosmetic importance. Sometimes it may be a polydactyly, having an extra small finger. It may be of cosmetic importance, not of any functional interruptions, but may be of use in certain diagnosis to find out the etiology. And these defects can be isolated. That means they can occur as single or multiple or as a combination. Then you call them syndromes. So that's the one form of classification. And the second one is based on developmental process, that is malformation, disruption, deformation, and dysplasia. Let's see what is this. See, from fetal stage, that's conception is drawn as a square. That's a normal conception, and normal development is drawn as a single line, and birth means a triangle in the end. See, that's a normal case. So if some insult happens during the fetal life itself, which is bringing about some change in the development, then that case, you can see a triangle. That means change, shape itself is changed and followed by a dotted line. That means it's not normally taking place. Excuse me. So this means there is an inherent problem in the fetus, which had led to an abnormality later on, and that is called malformation. Whereas in case of disruption, the fetus will be implanted normally. It may have started growing normally, but during the fetal life, some sort of interference occurred there. Thereafter, see, it is shown as dotted line. That means it is disruption. Usually, in case of amniotic band syndrome, when amniotic band will turn around certain organs like limbs, then causing amputation of limbs because of the ischemia distal to that obstruction. So that's such case you call disruption. Whereas the tissue is formed normally, it is growing normally to a certain extent, but due to some mechanical force, it is changed. So it's changed like upside down. And so that is why there is a change in shape or structure, and that you call deformation. That's typically the example is the club foot. Whereas in the last one, you can see initially itself, it is not a square, it is a circle. Initially itself, it's not a normal shape. And while growing also, it's not a normal shape. That means abnormal tissue organization. That means dysplasia. Okay, so these are the 4 abnormalities in morphogenesis. Let's see each of these in details. I told before, malformation means it's the primary structural defect of an organ or part of an organ that results from an inherent abnormality in its development. I think now you can all go back to that picture and remember like this. So examples are congenital heart defects like ventricular septal defect, cleft lip and palate, meningocele, like that. These are all major. Okay. This VSD and meningocele major, and cleft lip and palate can be considered small, can be considered as minor. The problem with this is, why do you need to know all these malformation disruption or not? Because you want to know the prognosis and the risk of recurrence in for subsequent pregnancies. So because if it is an isolated malformation, that means it occurs as a single malformation, risk of recurrence is 2 to 5%, whereas it is multiple malformations or complex, that is including syndromes, then the risk may vary or it may increase. Whereas in disruption, it is abnormal structure of an organ as a result of external factors like ischemia, infection, trauma, disturbing the normal developmental process. Example, I told amniotic band syndrome may even cause the constriction can result in amputation of digits, or a thromboembolic phenomenon intrauterine can also result in loss of digits like that. So usually non-genetic and do not recur in family. That is the prognosis of that. About deformation, it's the defect resulting from an abnormal mechanical force that distorts an otherwise normal structure. Example is Talipes equinovarus, plagiocephaly, like that, and they may have a good prognosis with postnatal intervention, and the risk of recurrence is said to be low if the causative factor does not recur. Whereas in dysplasia, it's an abnormal cells itself, that the tissue itself is abnormal, as in achondroplasia, ectodermal dysplasia. Here, most of the dysplasias are single gene disorders. So you can predict the risk of recurrence according to that. That means single gene disorders are like autosomal dominant, recessive, X-linked recessive, like that. Then in such cases, you can predict the risk of recurrence. So of these 4 different defects, malformation and dysplasia are actually really problematic in these 4, whereas disruption and deformation, relatively good prognosis among them. Okay. So now we've told about each of the different abnormalities in morphogenesis. Now let's see, when all these abnormalities come in combinations, then what do you call such groups? So there comes the multiple abnormalities in the form of syndrome or sequence or complex or association. So let's see these. Syndrome means it's all these different malformations occurring together, and definitely or presumably they should have a common etiology. That means some etiology is identified in case of syndrome. Whereas in sequence, pattern of multiple defects, multiple defects resulting from a single primary malformation. Then anomaly, this complex means anomalies of several different structures which lies in the same local body region during embryo. That means they might have been together during the embryonic development and some abnormality had occurred that time, but when they grow, different forms of, I'll explain that later. Then association means it occurs more frequently than expected by chance alone without an identified common etiology. So these are the 4 various occurrences of multiple abnormalities. Now let's see what are these syndromes. That means I told no, they have a common or identifiable etiology. For example, All these are syndromes. Down syndrome. What is the etiology of Down syndrome? It is trisomy 21 because 21st chromosome is there in 3 copies. What about Turner syndrome? Only one X chromosome is there. That's called monosomy X. Then Diagnostics syndrome, 22q11 deletion. Williams syndrome, 7q11 deletion. Prader-Willi and Angelman syndrome, 15q11 deletion. Miller-Dieker syndrome, 17p13 deletion. Smith-Magenis syndrome, 17p11 deletion. I'm sure that it's very difficult to remember all these syndromes, and I still say no need to by heart, but I just presented this because I wanted to tell you there is an etiology for this syndrome. That's what. So now going to sequence. Sequence means there is a primary defect, and that subsequent to that, so many defects will follow. For example, in oligohydramnios or a Porter sequence, what is the primary defect? It is renal agenesis. What happens? Lack of urine or oliguria. Then what happens? Amniotic fluid will be less. This will result in pulmonary hypoplasia. Due to death can result from respiratory insufficiency, or because of less fluid in the amniotic cavity, fetus will be compressed. So there will be altered facies as well as breech presentation or some abnormal positioning of hands and feet. So this is the sequence. One primary defect is there, but that is leading to so many abnormalities. Now coming to complex, I told before in the embryonic period, wherever these organs had been together or that particular areas had been together, some abnormality must happen. And while they grow, they will be having different abnormalities, but they altogether we call it as a complex. But as the name suggests, it's very complex and it's very rare also. Very low incidence, like 1 in 2 lakhs. And severe defects can occur due to impaired development and migration in case of complex disorders. Okay, they are pretty difficult to survive also. And one such example is OEIS complex. That's a mnemonic for omphalocele, extrophy, imperforatinous, and spinal defects. Just to mention that. That's all. Now coming to association, I said that means certain disorders, defects will be grouped together and they are not occur by just a chance. So it is usually seen in common. Okay, so that one is ventral abnormality, that mnemonic is vertebral defects, imperforatinous, cardiac abnormalities, tracheoesophageal fistula, radial and renal anomalies, and limb anomalies. Whereas charge association is coloboma, heart disease, atresia coinae, retarded growth, genital anomalies, and ear anomalies. So this, as science is advancing, as more and more tests are coming, some causes are identified for these also, and charge anomaly has got some genetic genes identified also. So now I think we have told about what are the defects, what are the pattern of defects, and what are multiple defects. So altogether we have finished what are the defects. So now we want to know what are the causes of these defects. So altogether, there are 3 different causes. One is genetic, one is environmental, and one is unknown. And you can see the percentage. Unknown causes are more. It's about 50%. It's unknown causes. That means yet to identify causes. So we have identified only up till half of the causes. Okay. And genetic comes to about 30 to 40%, and the environmental comes to 5 to 10%. And out of genetic, chromosomal is about 6%, single gene 7.5%, and multifactorial is 20 to 30%. About environmental, drugs and chemicals, infections, maternal illness carries 2%, and physical agents like teratogens, like they carry this radiations carry 1%. So that's the etiology wise or the distribution of the cause. Now we told about the major malformations, a combination of malformations, but there are some minor abnormalities also. So that I had listed few of the minor structural abnormalities you may come across in your OP or routine practice, and I'll tell you what the importance of them also. So one is pre-auricular pituitary tag, epicanthic folds, lacrimal duct stenosis, brushfield spots in the iris, lip pits, single palmar crease, fifth finger clinodactyly, syndactyly between second and third toes, supernumerary nipples, umbilical hernia, hydrocele, sacral pit or dimple. So the importance of this is if they occur in isolation, you need not be alarmed. That means not much of a big thing, but you should really search for other problems in this child. Because say 15% of neonates may have a single minor anomaly. and 0.8% of neonates have got they can have this much percentage said to have 2 minor anomalies, and out of them 10% have associated major anomaly, and about 0.5%, that's even smaller percentage, is said to have occur 3 or more minor anomalies, and out of them 90% may have associated major anomaly. So now you understood what is the importance of noting down these minor anomalies and how to see. That is another thing is, see, if you some preauricular skin tag, then no need to get alarmed, but you should definitely look for a renal abnormality. So an ultrasound abdomen or ultrasound KUB is essential for that child, but you shouldn't make that parent anxious about telling this is a real big problem. So that is the important. That's how you deal with. So now certain conditions present with. So now we have finished all the anomalies, what all you have to notice, or what all you see. But then how to move forward, you have to know which all conditions will present with dysmorphism. So the 4 groups are chromosomal disorders, microdeletion syndromes, single gene disorders, and multifactorial disorders. Chromosomal, as you know, Down syndrome, Turner syndrome, and trisomies are there, 13, 18, like that. Then microdeletion syndromes, Diagnostics syndrome or the villocardiofascial syndrome, Williams syndrome, Prader-Willi syndrome, Angelman syndrome, Miller-Dieker syndrome, Smith-Magenis syndrome. Then your single gene disorders like Noonan syndrome, Marfan syndrome, Cornelia-de-Lange syndrome, Fragile X syndrome, mucopolysaccharidosis, achondroplasia, and multifactorial disorders like neural tube defects. This is just an overview of which all syndromes are associated with dysmorphism. So now we'll deal with each one by one. First and foremost, I think no one is doubtful about identifying a Down syndrome, first described by Dr. Langdon Down. And it took actually 1 century to find out the chromosomal basis of the syndrome by Lake June and colleagues. And it is now still also, it's the most common autosomal chromosome syndrome. So now how will you find? You have to know the classical findings in Down syndrome. You know that craniofacial findings are, brachycephaly, epicanthic folds, protruding tongue, small ears, upward sloping palpebral fissures, limbs, single palmar crease, small middle phalanx of the 5th finger, wider gap between the first and second toes, that is called sandal gap. Then cardiac abnormalities, atrial and ventricular septal defects, common atrioventricular canal, Paed ductus arteriosus. Then other abnormalities, anal atresia, duodenal atresia, Hirschsprung disease, short stature, strabismus, like that. But altogether, there are actually so many to tell, but I selected few which are, I preferred to be choosy with the different features of Down syndrome. But then in newborns, again, it's little different. Like there is a criteria called Hall's criteria, which has got 10 points, and under which 4 or more are there. Then you can, because a newborn baby for any syndrome, not many of the features may be so much visible. And if at all they have see, for example, depressed nasal bridge, you see in newborn. It is so common in newborns, right? Their nasal bone will grow later only. It will not be like adult nasal bone. So you cannot label them as a depressed nasal bone. It's an abnormality like that. So that there lies the difference in newborns. Okay. So, for that, you have to keep that into consideration whenever you diagnose a syndrome or a dysmorphic feature in newborn. So you have to be really careful when you talk about that in a newborn. So in Down syndrome, the poor morose reflex, hypotonia, flat facial profile, upslanting palpebral features, dysplastic ears, redundant loose neck skin, simian crease, hyperextensible joints, pelvis dysplasia, hypoplasia of 5th finger middle phalanx. So out of these, if you have 4 or more, then you can diagnose Down syndrome in newborns, I do. Okay, so now before that, few more points regarding Down syndrome. It is said to have association with an increased maternal age. That means as age advances, more chance of. So altogether, the normal incidence in normal population, it's about 1 in 800. And as age advances, it goes up to when it reaches 40 years, 40 to 45 years, it's said to have risk up to 1 in 50. That is so much of a high risk, isn't it? Because of that maternal, what is the commonest cause in Down syndrome is the non-disjunction during maternal meiosis. So that is why these oocytes actually are formed in the intrauterine life itself, and they've got a good cycle throughout the life of the female. So that's why they are subjected to adverse situations. So that is why more of maternal meiosis disjunction is important in case of Down syndrome. But other than that, you can get translocate this not only free trisomy, translocation and mosaicism, but I'll deal that in the later, next class of genetic testing. That's why I didn't put in this slide. Okay, so that's about Down syndrome. Then coming to the next one is trisomy 13. Again, three chromosomes are there for 13 number, and you can see this. Excuse me, I'll just take the cursor. Can you see the pointer?
Yes,
Yeah, we
miss.
can see.
Okay. So here you can see there is a one baby with a bilateral cleft lip. That means that midlines, it's so much of defect in midline. That's so characteristic of trisomy 13. And here you can see a broad nose and a post-axial polydactyly in this child. So that these are the characteristic features of trisomy 13. Even though they'll be having lots of features, there may be few that I'll deal that later. There may be few characteristic features that you can tell a spot diagnosis of this trisomy 13. So likewise, you have trisomy 18 or Edwards syndrome. See, in this child, you can see a prominent occiput and you can see a small mouth, then clenched fist. That's so characteristic of trisomy 18. Clenched fist like this, very much overlapping of fingers, and also rocker bottom foot means a foot in the shape like this, that sole. Here that's heel, no? Heel takes the shape like this. So it's called rocker bottom foot. So that is the classical feature of trisomy 18. So then now coming to Turner syndrome. So you know it is monosomy X means it's only females have 46XX, that is 2 X chromosomes. Males have 46XY. Whereas if it's only one X chromosome, it is monosomy X, that is Turner syndrome. So how will be the clinical manifestations of Turner syndrome? In antenatal ultrasonography, usually you can find generalized edema or hydrops, that's called hydrops, or sometimes a nuchal pad. That's fluid collection in the nuchal area, that's back of neck. So that's suggestive of Turner syndrome. But at birth, usually the children may look entirely normal. In contrast to Down syndrome, usually in Down syndrome, at birth itself, we are able to pick it up. Usually not missed, except few cases of Down syndrome, mosaics, that too, usually not missed. That's why from my experience, I can say usually not missed. But for Turner syndrome, they don't look with that classical features of Turner syndrome at birth. They may look like a normal baby, but there can be sometimes you can see a residue of intrauterine edema with puffy extremities or neck webbing, very rarely. But otherwise, the findings are you can have you see a webbing of neck. Can you observe this webbing of neck in this child? This one. Then this wide chest, that is wide chest, and so widely spaced nipple, and here it's not so clear, wide increased carrying angles. Then other features are short forth metacarpals. There are so many features, but I'm talking about the classical ones. Okay. Then the two main medical problems that come to us. So I said at birth it is not identified. So when will we identify these children? So usually in our experience, in our clinical experience, they will be brought as short stature. Or when they reach puberty, they'll be brought as ovarian failure. That is primary amenorrhea. So short stature and ovarian failure are the two important clinical presentations in Turner syndrome when they come to you. So usually, as I said before, short stature becomes apparent by mid-childhood, by about 10 to 12 years. Then only then this mother, they'll notice. And most of them, they'll say the child is standing in the front row in during the assembly, and child can sit the child sits in the front row of the class. Like that, they'll say. So that is when you find out that, okay, the child may be having short stature. And usually they require growth hormone treatment, but still average, without that, average adult height is 145 centimeters. Whereas ovarian failure commences during the second half of intrauterine life and almost invariably leads to primary amenorrhea and infertility, because I told this ovaries are actually streak ovaries. That means it is non-functional, very atrophic ovaries and an infantile hypoplastic uterus. So because of that, they'll be surely developing primary amenorrhea and infertility in future, which may require estrogen replacement therapy during adolescence for the development of secondary sexual characters. So that's about, I just wanted to explain the clinical side of Turner syndrome also. So now going to the next one, that's Williams syndrome. It's a microdeletion syndrome where a few, small region of the area of DNA is deleted, and that results in certain classical features like mild short stature, full lower lip, and sloping. So this is this second one. This is so much close to what we see. That they are called. That's called Elfin facies. Let us see. You can see full lower lip and little everted and a full lower lip. So that is so characteristic of Williams syndrome. And these sloping shoulders and also not so universal, but I had this picture, so I kept it. And stellate arrows that are said to be one peculiar feature of this. But they have, usually they are very friendly kind of children. They come to OP, they get friendly with us, very friendly kind of children, and all are intellectually impaired. And usually their reproductive life is, they do not reproduce also. So that is about Williams syndrome. So when you see this particular child with a friendly nature, mild short stature with a fully everted lower lip, that typical facies with a extended philtrum, there you can suspect a Williams syndrome, and that is the reason is 7q11 deletion. This is certain syndromes I wanted to just to show certain classic features of each of the syndromes that's not so popular or not so commonly found. Vanderbilt syndrome, where you can see a posterior cleft palate and lip pits. That's so classical of this syndrome. Then deletion 1p36 syndrome, where the child is having very straight eyebrows and their child can have seizures and learning difficulties. Cleave-Strauss syndrome, which is deletion 9q34, where you can see it's very pretty arch eyebrows, narrow upslanting palpebral fissures, brachycephaly, prognathism. See, this child is having prognathism and severe intellectual disability. This is just this is not for you to by heart or anything, just to let you know that whenever you come across a syndrome, you have to know the few of the classical signs or the characteristic features of that syndrome. That's why I put these slides. Okay, coming to the end of the syndromes, you remember that slide? Chromosomal disorders, microdeletion disorders, third is single gene disorders, and fourth is multifactorial disorders. So there, actually, we have just mentioned two of the main syndromes. That's Down syndrome, Turner syndrome. Then single gene, like mostly, like it's a different thing, like each having different features, like Marfan syndrome, tall stature, combination of this cardiovascular malformations, like a coarctation of aorta, then a subluxation of lens, then this skeletal abnormalities like pectus et carinatum, excavatum, like that. So that is about the syndromes. So then multifactorial means it has got a genetic as well as environmental. That means both genetic and environmental factors come into play in case of multifactorial syndromes. So the commonest syndrome we come across is neural tube defects, and that is actually a spectrum of defects based on the location. That means, see, it is this, you can all see this neural tube, which is getting closed by about 28 days. If it doesn't get closed properly, in that defects only we call neural tube defects. So in the cephalic side, you can see if it doesn't close, that means this skull is not closed, and that's called anencephaly. Whereas in the caudal side, if it doesn't close, it can result in myelomeningocele, it's an open neural tube defect, or a defect in the spinous process that is called spina bifida. So this is about neural tube defects. That's also based on the location. And the etiology I told most common is a multifactorial, but there can be syndromes associated with it, like trisomy 13, 18 can have neural tube defect, or a Meckel-Gruber syndrome that also can have neural tube defect, and a maternal valproate intake that is said to have this it can produce neural tube defect. So that is very, very important. What is the importance? See, I told it's very common to come across neural tube defects very commonly, but what is the importance is you have to know the recurrence risk of that. If one child is affected, parents having one child affected with you imagine the morbidity which is occurring in a child with myelomeningocele, because the child is having a problem in the lower body only, isn't it? Child is having normal intelligence, which will grow normally, but the limbs are not working. So the lower part is not functioning well. So it can have associated problems like urinary abnormalities, recurrent urinary tract infections. Okay, that's all about that. So that much of morbidity is there. So we have to know the recurrence risk, whether the second child will be affected. So that's about, if one child is affected, there is 3 to 5% risk of next child to get affected. And what is the prevention for this is with using periconceptional folic acid, because folic acid is required for proper neural growth. So that is why you have to provide periconceptional folic acid. That means normally we give 0.4 mg folic acid for all pregnancies, because you don't want any pregnancy to get affected. So, but if one child is affected, then you give 10 times the dose, that is 4 mg folic acid from next pregnancy onwards. So that is very, very important. And periconception, that is also important. In fact, you have to take it before implantation. So you have to take it 1 month prior to conception, then to be continued for 3 more months after conception. So that's a very, very important advice you should give. It's not like after knowing that the lady is pregnant, then you have to take. No, it's not like that. You have to take 1 month prior to becoming pregnant. So you have to always counsel like that. So that is about a multifactorial disorder, neural tube defect. Then another thing, in the first few slides, I showed a table, genetic factor, then this chromosomal genetic factor, environmental factor, and unknown factors. So we told about this genetic factor so far. Now the environmental factor, purely environmental factor, is the fetal valproate syndrome. That is mother taking valproate during pregnancy, child can get. So see, you can see this, those I have shown in yellow is classically that's present in this child. The child is having a high forehead, a broad nasal bridge, a short nose with anti-verted nostrils. It's everted outside, then a long philtrum, and the thin vermilion border. Vermilion border is the border between the lip and the skin. So these are classically present in fetal valproate syndrome, like that. That's seen in this case also. But there are other problems like growth and mental retardation, eye defects, hearing loss, nail hypoplasia, triphalangeal thumb, cleft palate. It need not be present in all the cases, but invariably it can present in these this kind of fetal valproate syndrome. So that is about fetal valproate syndrome, one of the environmental influence of environmental factor to produce a dysmorphism. So now I have put a picture to those postgraduates. I'll tell you the classical features present in this child. See, this child is having coarse facies, macroglossia, a protuberant abdomen, and an umbilical hernia. So can anyone suggest any diagnosis for this child?
Mucopolysaccharidosis.
Okay, that's a good guess. How did you guess that? No, why did you guess that? Is it from coarse facies, macroglossia? Yes, very good. Yes, it was a good guess. So everything can occur in mucopolysaccharidosis. Now I'll give another set of conditions in this child. Now you go back to the diagnosis again. This child is having wide open fontanelles, hypotonia, hoarse cry, inactivity, poor feeding, prolonged neonatal jaundice. Any take on this?
Hypothyroidism.
Very good. Hypothyroidism. Very good. Who answered that? Anyway, I don't know all of you. Okay, that's good. So this is very, very important. Why I wanted to keep this slide was, this is one non-genetic cause, okay, to cause a dysmorphism. And as a pediatrician, I feel it will be a crime if you miss a case of congenital hypothyroidism without diagnosing, because it is a treatable cause of mental retardation. So whoever is seeing such children should have a suspicion of congenital hypothyroidism with all these features. You should order a thyroid function test so that you can revert back somewhat. Okay. So just about congenital, it is usually sporadic, as I told. It's like, see, sporadic means it's like like an accident, right? It just happens like that. It's not of any genetic basis. And severe hypothyroidism does not give rise to growth deficiency until after birth. That is the problem. So after birth only it gets manifest, and the grave problem in this congenital hypothyroidism is it will cause irreversible brain damage. So an early diagnosis and adequate thyroid hormone therapy is necessary for mental function. So that's the importance. That's why I wanted to mention this very, very important thing under congenital hypothyroidism. And that's one of the DDs of course species, along with the diagnosis, differential diagnosis of leukopolysacchardosis. So now I think we have finished one part of my presentation. That's an introduction to the birth defects. What is dysmorphism? What are the combination of anomalies? What are the etiologies, and how do they present, and what are the various types of genetic disorders that can present with dysmorphism? Now you have seen one child with dysmorphism. How will you proceed further? Okay, so these are the steps how we proceed to evaluate a dysmorphic child in reaching a diagnosis. Number one step is a detailed history, including a 3-generation pedigree. That is very, very important. Number two, phenotype assessment. That means you want to find out what that condition is. For that, you have to have a systematic head-to-toe and systemic examination. Then after this, you have to reach a etiological diagnosis. You can do relevant investigations. At the same time, you can have a literature search also to reach a etiological diagnosis. And next is you have to identify functional disabilities like developmental delay and deafness, like that. Now, finally, as I told, this is very, very important part of genetics consultation. You have to counsel the patient. That is both pre-test and post-test. Pre-test means before testing itself, you have to describe about the problem, why this, what the purpose of this testing is, what will you expect, what are you expecting from the test, everything you have to explain to the patient. Otherwise, you see these tests are so costly, some that they come back and you don't get a definite result, then that creates confusion. So you shouldn't create confusion while dealing with them. Already they will be very anxious. And another thing about this thing is dysmorphism. I wanted to tell you in the beginning itself, don't categorize these children as abnormal and never say abnormal to the parents, because it is just an alteration in shape. So you can also present it very lightly that this is just an alteration in shape. Okay. So now why do you need this etiological diagnosis? Once you see a dysmorphic child, you want to find out what condition it is, because early detection of treatable complications. If any problems related to that is treatable, for example, a Down syndrome, you are finding out a Down syndrome, you will immediately do an echo. No doubt, you will straight away go and do an echo. Why? You want to rule out a congenital heart disease. If it is some repairable conditions, then that will be very helpful. It will prevent all the fatal problems that can occur in future. Also, if you know the diagnosis, you can always assess the risk of recurrence in future pregnancies. So this is how it will help you. Now we'll see steps, each one step by step. So first and foremost is the history. History always starts from the intrauterine life itself. So ask about the antenatal history, the drugs taken by the mother. We've already told one example, valproate. Infections like intrauterine infections. I think you are all familiar with the torch infections, toxoplasma, herpes, like that, rubella, cytomegalovirus. Then your this varicella, exposure to radiation, that is important. Maternal illnesses like diabetes mellitus, epilepsy. Diabetes mellitus, it can cause fetal, the sacral agenesis, all these malformations in the fetus. Epilepsy importances, anti-epileptic drug intake, that is very, very important. Then, of course, the ultrasonographic findings. I have just mentioned only one of them. Example, nuchal edema suggests chromosomal disorders. Actually, there are n number of ultrasound findings which will tell you this suspicion of any genetic disorder or any the syndromes related to dysmorphism. There are so many of it. I didn't mention them, but if you come across in further practice, then you can also go through them and try to find out the correlating syndrome of the particular diagnosis. So that's about the antenatal history. Now the proper history, family history is very important. The 3-generation pedigree is important. Why? Because you want to know whether this will help you in find out the mode of inheritance of the genetic disorder. As I told, autosomal dominant, autosomal recessive, and X-linked disorders. This and sometimes mitochondrial disorders also. So this makes you easier to find out the mode of inheritance from a 3-generation. So minimum 3-generation pedigree. Sometimes in clinical practice, we may even go till 5-generation pedigree. Sometimes, like if many number of family members are affected, sometimes it may. But minimum, I said, you need 3-generation pedigree. Then age of the mother, I told our condition before, that is Down syndrome, correlation with the advanced maternal age. So that is very important. Then consanguinity is another thing you have to get from the family history, because consanguinity is associated with increased risk of autosomal recessive disorders. Why? Because what is consanguinity? It is having the chance of having a common ancestor. So common ancestor is so near you, that means the degree of consanguinity is very small, that is very near there. So that means the proportion of genes shared between those persons will be more. It is not like general population. So for in general population, you can have sometimes 2 or 3 maximum 5 genes defective. But in case of consanguinity, if these two carriers, these two people are having they are carriers of the same gene, then mating will cause this offspring to have an autosomal recessive disorder, that to about 25% chance. So consanguinity reason is the percentage of genes shared is more. Actually, that is like 1st degree, 2nd degree, 3rd degree and all, but just understand this way. So then the recurrent abortions and stillbirths in the family, that's also very important, because this tells you, usually they'll come with a history of recurrent abortions, stillbirths, but usually we don't know why it happened, isn't it? Why that abortion happened. So as of today's literature, it is said that about 50% of the abortions, that is abortions, chromosomal disorders are responsible. So that is why that also very, very. So this gives you a clue that what sort of problem could have that fetus had. Okay, not sure, but a doubt. So that is the importance of asking recurrent abortions and stillbirths. Then the genetic disorders in the family, any disorder or a previous child with genetic disorder. So anything like that. So then you have to have an idea of what this family is going through, or what to suspect and how to proceed. Then going to the present or past history of the child itself, growth and development, very, very important, because most of the syndromes may be associated with short stature and developmental delay like that. So that is very important. Also, other symptoms like convulsions, which tells you a neurological problem is there. So you have to assess the neurological problem, sometimes the functions of the brain, that is important. Then vision and hearing defect, again a developmental delay associated with the vision and hearing defects tells you, it gives clue to so much of many of the malformation syndromes. Then any possibility of inborn errors of metabolism, that characteristically they are characterized by progressive course of the illness, these inborn errors of metabolism. So that is also important when you take a history of the child. So that is about an outline of history, but definitely you have to take a detailed history of each and every point. I just told the highlights of the history. So now the second step is phenotype assessment. You want to assess, or you want to come to a diagnosis. So how will you assess? For that you can do a good physical examination as well as a literature search. So physical examination always, it begins with general examination. I know that you are all familiar with how to do a general examination, a general comment, vital signs, then this pallor, cyanosis, clubbing, like that. Then you have to have a head-to-toe examination, then an anthropometry or the growth assessment of the child, and a developmental assessment of the child. So that is very, very important. Head to toe, I think I have a few more slides related to that. A systemic examination of that means whichever relevant system we have to examine. Then, of course, one more point is the examination of parents in case of familial disease. For example, most of the time when we see for example, Noonan syndrome. We had a patient, Noonan syndrome, and the father was also Noonan syndrome. So it's an autosomal dominant condition. So so mother took the child, and when we saw we were suspecting clinically Noonan syndrome in that child, but just we wanted to see the father also. When father came, he was also looking the same. He also had the same phenotype of Noonan syndrome. So similarly, suppose if you see a dysmorphic feature, for example, like small palpebral fissures or ptosis, such features like isolated features, then if you examine parents, so sometimes one of the parent may have such feature. So what does that tell you? It is just familiar. You need not take it as a big thing, like a big syndrome is going to be diagnosed. You need not scare them with telling all this. So you can just reassure, okay, father is having mother. So polydactyly, most of the families, like we have seen polydactyly also like this. So isolated distinct abnormalities and the presence in the parents sometimes will help you in this way to diagnose as well as to reassure. Okay. So now the literature search. This, along with physical examination, you may require a literature search because you will be having a collection of abnormal defects, a list of defects taken from the child from head to toe you are taking. But then you have to fit everything into one. It is like a puzzle where you have to fit everything in that and finally find out the answer. So we have got certain databases where you can search these diagnoses from when you provide these clinical details. One is the online Mendelian inheritance in man, that is OMIN. That is free to all. Anyone can access that. You can always feed your this. For example, you can epicanthic folds, hypertelorism, like that. You can feed the clinical feature or the relevant features, and you can get a set of diagnosis. But the problem with that is you have to use good handles. Good handles means which is specific to the that particular syndrome. Then only you will get. So I'll explain that in the coming slides. Then you have another, this thing is elements of dysmorphology, that's also free access. That will tell you what, for example, if you say hypertelorism, what is your concept, or if I say small eyes or like that. So it has to be there has to be uniformity in that. So you can find those particular features like microcephaly, this micrognathia, everything small this each of the features will be properly described in that, how it is. Okay, this cranial abnormalities, craniosynostosis, like that. Like Wiley online library also, you can search for this certain conditions or syndromes. And now one important point in relation to this I wanted to tell you is HPO, or that is called human phenotype ontology. That means it's a standardized vocabulary for phenotypic variations in order to have a uniformity of nomenclature, because this site will provide you a search term. That means if you want to search hypertelorism, you can search in HPO whether such a term is an acceptable term. So if you search or I search, it should be a same term. So there won't be any difference. So that for easiness, for the uniformity of nomenclature, if I search from here or some other place also, you can do it that way. So this human phenotype ontology that particular term is the preferred term. You have to choose those terms from HPO. If you find some polydactyly, you can go and see what exactly that is. Okay, it is recommended or it is found in that HPO site. Okay, you can select that and add in other search databases. So that is it. That's about databases. So now about a detailed head-to-toe examination. I know that I thought for postgraduate sake only I put three, four slides of explanations of each of this because I think in order to get familiarized with these terms. So from head to foot, why is the importance? You have to look every minute point in the child. So that is the difference from adults also. See, adult examination, you are not looking anything like head to foot or anything. And another thing is most of the time children are coming to us, right? So in that stage itself, whichever problems they have noticed or mother have noticed, some even the patch in the skin, hyperpigmented patch in the skin will be a worry to the mother, and they mostly will bring the child to us. So that is because we are there, we are there for them, right? So they, I mean, pediatricians are available for them. So they, when they come to you, so it is your job to look every point in head to toe examination. That's why I put these slides. So in head, you have to look at the size. See, microcephaly. Why? What is the importance? These are the conditions. Actually, it's a long list of conditions for each of this. I just shortlisted to 2, 3 for your knowledge. Chromosomal and single gene disorders, fetal exposure to infections like Toxoplasma rubella, Zika virus, macrocephaly in Fragile X syndrome, achondroplasia, brachycephaly, Crouzon syndrome, plagiocephaly, craniosynostosis deformations. Then coming to eyes, so it is like head to toe, right? Eyes, hypertelorism, Reduchat syndrome, Wolff-Hirschhorn syndrome, ptosis in Smith-Lemli-Opitz syndrome, Kern-Sayre syndrome. Ears, malformed and posteriorly rotated ears, which are often low set in trisomy 18, in triploidy, Smith-Lemli-Opitz syndrome. Microtia, that's small ears, hemifacial microsomia, Treacher-Collins syndrome, retinoic acid fetal exposure. Then nose, prominent bulbous tip in 22q112, microdeletion, anteverted knee wrists, Cornelia de Jong syndrome, Smith-Lemli-Opitz syndrome, philtrum, long philtrum in Williams syndrome, and smooth philtrum in fetal alcohol syndrome, mouth and throat, macrostomia, that's a large mouth in oculovertebral spectrum, Angelman syndrome, and microstomia in trisomy 18, then high arched palate in Marfan syndrome, cleft uvula in 22q112, microdeletion syndrome, widely spaced teeth in Angelman syndrome, then protruded tongue due to macroglossia, such as Beckwith-Whitman syndrome, Pompey's disease, tongue thrusting in Down syndrome, and other conditions with poor orofacial muscular tone. Coming to neck, broad neck Turner syndrome. It's because of that webbing, broad neck Turner Noonan, short neck in Down syndrome. Chest, pectus excavator Noonan's dystrophy, Noonan syndrome, and pectus carinatum, Marfan syndrome, widely spaced nipples, Turner syndrome, Noonan syndrome, abdomen hepatomegaly with or without splenomegaly, glycogen storage disease, Gaucher disease, and Niemann-Pick syndrome. Genitalia, ambiguous genitalia in Bagger association, Robinow syndrome, Smith-Lemli-Opitz syndrome, micropenis, Prader-Willi syndrome, Robinow syndrome, cryptorchidism, Prader-Willi syndrome, trisomy 18, 13, trisomy 9 mosaic, spine abnormalities like thoracolumbar scoliosis, neurofibromatosis type 1, Marfan syndrome, skeletal dysplasia, vertebral segmentation defects in Alagili syndrome, Bacterial associations, deep sacral dimple, sacral hair tufting, sacral tag in tethering, that is our neural tube defect, skin, hair and nails, sparse hair in ectodermal dysplasia, and hair color lighter than expected in albinism and Chidiac-Higashi syndrome. Sorry for this long, exhausting list, but you should be familiar with these three. These are polydactyly in Carpenter syndrome, Bardet-Biedl syndrome, trisomy 13, syndactyly in Smith-Lemli-Opitz syndrome, Eppert syndrome, brachydactyly in 2q37 deletion syndrome, skeletal dysplasias, arachnodactyly Marfan syndrome, then broad thumbs and toes in Rubinstein-Tybee syndrome, Sither-Chosen syndrome, clubfoot in Porter syndrome, deformation sequence and distal arthrogryposis. Then skin pigmentation in hypopigmentation, tuberous sclerosis, skin color lighter than expected in albinism, full or partial albinism. Okay, so this the importance is, see, now you understood so many things are to be checked in a head-to-toe examination. I wanted to let you know the magnitude of how much you have to examine that. So you have to keep in mind all these features before going to the phenotype assessment using a clinical examination. So now the two steps are over. One is history and the second one is phenotype assessment. So after phenotype assessment, you are going to reach a diagnosis. So diagnosis, why? Diagnosis tells you the etiology also. So most of the time, we will be reaching a syndromic diagnosis. And regarding this syndromic diagnosis, one important thing is if there are typical dysmorphic features, and that's called gestalt diagnosis. That means, for example, Down syndrome, they've got a typical uh, facial features. So you won't get confused to diagnose again Down syndrome. That means the moment the child enters the door of your OP, you will tell that it is Down syndrome. That is what it is called, gestalt diagnosis. Then they are called then there are certain clues to the proper diagnosis, and they are called pearls of dysmorphology. So with this introduction, we'll go to each of the syndrome with a gestalt diagnosis. I mean, few of the syndromes. So coming to Noonan syndrome, which I told before. See, the ones which I have given in yellow. Uh, Excuse me, Dr. Roshni, we have enough time, right?
Sure, ma'am, sure.
Okay, yeah. So down slanting palpebral fissures. See, can you see palpebral fissures little slanting down? Then a hypertelorism. Eyes are widely placed. There is ptosis obvious. Strabismus is there. That is squint. Then see the looser tears, increased width of mouth, and a short webbed neck. So these are the classical features in this child. So when you see a child like this, usually one diagnosis coming into your mind is Noonan syndrome. Of course, other features like short stature will be there at 50% of children, low posterior hairline, cubitus valgus, congenital heart defects, cryptorchidism, all can be there. But these are the classical features usually we see. So to tell you the gestalt diagnosis, I showed you this slide. So Noonan syndrome, from the moment that you see them also, you will suspect Noonan syndrome. Okay. Next is the Rubinstein type syndrome. See, in yellow I have written the features that are present in this child. You can see again the palpebral fissures are little slanted like this. That's called down slanting. A hypoplastic maxilla, that means cheeks are not that full. Arched eyebrows and low set ears. There is a prominent beaked nose with the nasal septum extending below the ala nasi. See, ala nasi does this level, and this nasal septum is extending little more down. That is called overhanging columella. And the child is having, see, broad thumb and broad toes. So that is classical of Rubinstein type. The other features associated with that are intellectual disability, microcephaly, hypoplastic maxilla, clinodactyly, cryptorchidism, and flat feet. Okay, next one. This is Hunter syndrome. Someone said mucopolysaccharidosis before this because of the coarse facies. So here the child is having coarse facies. That means everything it's little large, looking large for the size of the child. Macrocephaly, but that you can identify from the sight also, but you have to measure and find out. Then you can see a full lips and a macroglossia because the tongue is protruded. So that is your Hunter syndrome, mucopolysaccharidosis. Associated features are intellectual disability, hepatosplenomegaly, inguinal hernias, joint contractures, kyphosis, cardiac complications, and airway obstruction. Now, this is another syndrome with the classical features. See, you've got bushy eyebrows and eyebrows meeting in midline. That is called cynophorus, and long curly eyelashes, depressed nasal bridge, a long philtrum, thin upper lip, and a micropnathia, small chin. So these are classical of Cornelia de Lange syndrome associated with growth and mental retardation, hirsutism, clinodactyly of fifth finger, and cryptorchidism. Next is Apert syndrome, which is a craniosynostosis of the coronal suture. So because there is a synostosis of coronal suture, what is happening is head won't grow antero-posteriorly. So this diameter will be very less. So head will be flattened from behind. There will be hypertelorism. Supraorbital horizontal groove is there. Shallow orbits with proptosis and total to partial syndactyly. See, this child is having syndactyly, means the fusion of fingers, and that's characteristically called mitten hand. And there can be agenesis of corpus callosum, ventriculomegaly, dental malocclusion, cardiac defects, genitourinary abnormalities. Now I think you are all thorough with the gestalt diagnosis. What's meant by gestalt diagnosis? At the site itself, you will suspect such a syndrome. So for that, you have to know for each syndrome, you have to know a classical features. Okay, so that's about syndrome diagnosis. Now going to the investigations. Role of investigations in syndromes or diagnosis of a dysmorphic child is to look for internal anomalies or any treatable entities in the child. That means you have to really find out what is. For example, it's Down syndrome, you are doing echocardiography. So like that you have to do. For Turner syndrome, you have to do a kidney abnormality, so you have to do ultrasonography. So like that. Also, it will help in the identification as well as confirmation of etiology. So the investigations available are, you can have biochemical investigations like your enzyme assays for lysosomal storage disorders. Then you can have imaging, neuroimaging for neurodevelopmental disorders, ultrasonography, then skeletal surveys for achondroplasia or skeletal dysplasias, echocardiography for all suspected congenital heart disease. And finally, to confirm, you can do a genetic testing with the testing options of karyotyping, FISH, that is fluorescent in situ hybridization, MLPA, Sanger sequencing, next generation sequencing. I think we are going to have a detailed class next time. So this is the investigations. Actually, I haven't named each investigations for each conditions, so that's not possible. So understand that what all problems that the child is having, which all investigations child may require. So as I said before, there you should have a functional assessment along with your systemic assessment also. For example, developmental assessment, how far the development of the child, as well as the vision and hearing assessment. So that is understood as a functional, that is done as a functional assessment. And finally, so after you have diagnosed the condition, you have investigated the condition, you have reached a confirmed diagnosis with the help of testing, including genetic testing, then you have to give a genetic counseling. So a good communication is the key of genetic counseling, and you have to stick on to ethical principles of genetic counseling. And they are autonomy, beneficence, confidentiality, non-maleficence, justice. Autonomy means, that means whichever you are telling the parents, you are talking to the parents, it should be non-directive. That means you are giving options. You are, from your knowledge, you are giving them how much or what about, for example, Down syndrome, recurrence risk. Suppose a baby is diagnosed with Down syndrome, parents are coming very anxious to you, what to do. Next pregnant, okay, I am pregnant next. And if you are done a prenatal diagnosis for the child, if the child is identified, the fetus in utero is identified as affected with Down syndrome, you cannot advise them termination. So that is the point in autonomy. That means it should be non-directive. You are not supposed to direct them towards the final decision. That means the decision should be theirs. But of course, you should be helping them to take a decision. That means you have to give options. This way, if you do this, this will happen. This way, like that, you have to tell them. Then the next is beneficence, means benefit of the patient. That means always you should talk in the benefit of patient. That means suppose this regarding the cost, 2 tests can be done, which is preferable, like that. So something which is pointing towards the benefit of the patient, that is very important. Confidentiality is another important thing. That means you have to keep everything, because you are dealing with in genetic situations or genetic consultation, you are dealing with the identity of patient, isn't it? This DNA, everything, test, everything is related to the identity of patients and all the confidential matters of their family. So you are taking very family matters relevant to the case. So it should be, and without their consent, you shouldn't share to anyone. Suppose if they come, usually the usual scenario is one couple will be coming with their child, and the next visit their grandparents also will be coming, some uncle, auntie, something like that will be coming. So that is also very important. So whom to share? With the consent of the parents only, or whoever is coming to you for immediate attention, with their consent only you can share the feature, the information with others. Otherwise it will create harm to them. So that is the next point. It is non-maleficence. That means do no harm. And in this context, let me tell you, I told before, whenever you come across a dysmorphism child, never admit or label them as dysmorphic. Just say an altered It is just a variation. Because I don't in the clinics, like we are all in the practice of discussing. That is all for academic purpose actually, but in front of patients usually it's going to happen. So be careful while dealing with these terms and explaining the risks of discussions with each other. So very carefully you have to deal. You shouldn't do anything to hurt them, because they are already lost their all confidence and morale and everything once they know about a very bad condition for their own child. So it's very much hurting for them already. So you shouldn't aggravate that. Okay, so that is non-maleficence, and justice means it should be justice should be given for. I mean, it should be justice should be given to all, irrespective of anything. So you are supposed to or manage them equally. Okay. So now, few more points. Talk with empathy. You have to understand the psychosocial and educational background. That's also important. See, if you go and talk about chromosomes, MLP and all, they won't understand. So you have to know how much education they've got and what is their psychosocial background, how much they are going to understand. So you have to, especially you may have to explain that in the simple language, their own spoken language sometimes. So that is very important. So they have to understand, and not using that I told before. And photographic documentation, if you are doing, it's only after written consent of the patient or the parents. Because for certain, and actually for this presentation, I've used photographs from texts only, because I haven't taken consent from which of the photographs that I have with me. So that is the thing. So if you use photographs, you should take the consent. That is also very important. So that's the first step of genetic counseling. Then a little bit about pre-test and post-test counseling. I told before that's pre-test. Why? Because suppose I'll tell you with an example. The child is coming. I mean, we'll take Down syndrome itself as an example. Down syndrome, see, there is no confusion in diagnosis. It's a straight cut diagnosis. You've reached you know that. So it's this breaking the news is also actually very difficult. I mean, making them convincing that the child is having a morbidity, lifelong morbidity with an intelligence impairment, and the possibility of major malformations like a heart disease. See, everything is so difficult talking to them. So you have to talk them in that way, as I said in the previous slide. Then you have to tell about what test to do. So then you have to have an accurate diagnosis, or a sure diagnosis of that, the need of the test, cost of the test, the turnaround time, how long will it take, and the yield of test. So that's, for example, if you take Down syndrome here, the need of the test. What is the need of the test? If suppose a child is coming to you with the trisomy 21 suspected, why do you need to test the karyotyping of the child? Because you want to know the difference, the type of the genetic mechanism in Down syndrome, because you know that there are three mechanisms. One is free trisomy. Second one is your translocation. Third is your mosaicism. And out of these, free trisomy and mosaicism doesn't carry a high recurrence risk. That means it's only 1% as in general population, and also the age-related risk of the mother. But for translocation, it carries a risk. If any of the parents are carriers of balanced translocation, then definitely they carry a risk to have another child. So that is the need of the test. So that you have to explain. Cost, usually it comes somewhere about around 2,500 to 3,000 for a karyotyping. Turnaround time, it takes about 2 to 3 weeks, sometimes 4 weeks. Yield of the test, mostly, unless there is culture failure, you should be getting a good karyotype. So like that, you have to explain pre-test. Now going to the post-test. So patient coming back to you with a positive karyotype, that is, you are seeing a karyotype 3 chromosomes 21 in that child. So how will you tell them? How will you break the news? So you can talk to them as we suspected. The diagnosis is sure of this child. Then you have to interpret the result. If it is free trisomy or it's a translocation like that, you have to interpret the result. Then you have to explain about the prognosis of the condition, treatment options, and its outcome. For example, in this treatment option, like for congenital heart disease, you can do surgical repair, like that you can tell. Then what about early stimulation, developmental stimulation of the child, then the follow-up of the child at regular intervals. You have to screen for hypothyroidism, then blood counts at proper intervals, like that. You have to approach the Down syndrome baby with a multidisciplinary team, specialist team. So that should be explain to them and its outcome. So with this treatment, how much the child is possible to improve, that also you have to explain. Then risk of recurrence in next pregnancy, I've told before. Then the preventive aspects also. So as a doctor, it's your duty to tell them the preventive aspects also, because no one in this world likes to have a child with deformities. So with all the available facilities, with all the present available facilities, you have to explain them how to prevent. So for that, you have the option of prenatal diagnosis as well as carrier screening. Prenatal diagnosis, I told, by amniocentesis or chorionic villus sampling. You can do by carrier screening, for example, if it is a cystic fibrosis, it is an autosomal recessive, then you can check the parents for the carrier status. So that why it is helpful, it will help the prediction of the risk of recurrence of next pregnancy. For example, it's autosomal recessive disorder, it carries 25% recurrence risk. Okay, so that is about the genetic counseling. So I think we are almost coming to the end of the presentation. So the conclusion, I would like to conclude with these few points. Like a good history and examination is still a gold standard. That's the physician's eyes are very, very important. And I would like to also add that saying that eyes see what mind knows. That means if you know the condition inside, then only your eyes will recognize that such a condition is okay, it is this. And pediatricians' role is really a pivotal role. That means because we are dealing these kind of children, all the children. So you shouldn't, that's from our side, you should take every attempt not to miss any child with dysmorphism. Once you find a dysmorphism, I told about minor anomalies. Sometimes it may be a minor anomaly. Of course, you have to search for other anomalies also, because a combination of anomalies is again suggestive of some that gives a clue to some internal anomalies also. So that is also very, very important. But dealing with them, talking to them, that is also very important. And the knowledge, a good knowledge about all the birth defects. Like I think I'm justified in bringing up few of the a collection or a comprehensive presentation of these birth defects, as a whole. But you have to definitely go back and read again and find out each of the points under each of the headings. Then a comprehensive evaluation when one defect is identified, a correct diagnosis which helps in the management as well as risk prediction. So that is very, very important, because genetic counseling, the first step is establishment of diagnosis in the proband. Who's proband? Proband means the person who's coming to medical attention. That is the affected person who's coming to medical attention is a proband. So suppose a child with thalassemia, parents are bringing a child with thalassemia, the child is the proband. Then what is thalassemia? Is autosomal recessive. So what will you do? First you have to confirm the diagnosis. How will you confirm? You will do all the blood tests. You will take the history. You will do a physical examination. Look for the particular characteristic hemolytic facies. That's otherwise called chipmunk facies, where you have all this frontal prominence, maxillary prominence, overcrowded teeth. Child will be having pallor. Icters may be there. Splenomegaly may be there. So like that, you will diagnose a thalassemia. Then what will you do? You will do a blood test. You will definitely find a microcytic hypochromic anemia. Then the next step, you can do a HP electrophoresis. You will find a fetal hemoglobin high level. And finally, you can do a genetic testing, HBB gene sequencing, which will tell, that's a Sanger sequencing, which will tell you this is thalassemia. So correct diagnosis is very important for management as well as risk prediction. And appropriate genetic counseling, I think I've dealt in detail about that. And the preventive aspects, one should know about it, how to prevent such disorders. So that also, you have to know that condition, you have to identify that condition, you have to offer prenatal diagnosis as well as carrier screening. Then with all this will ultimately, your aim should be to improve the quality of life. That means no one likes chronic morbidity. So whoever suffering from that, they really need our help. They have to improve the quality of life. And I can really mention that few of the mothers who have really taken off that leave from their job permanently, rejected their job and sitting for their children. So we have to really know about that their situation, and make sure or make every effort to improve their quality of life by offering good treatment options for the child. Okay. So that's about in summary about what we have handled. And I would like to mention two, three important points. This I mentioned before: dysmorphology databases, or mean elements of dysmorphology, phenomizer. There, the importance is you have to use HPO terms. But POSM is actually a pay. You have to make payment. The other this thing you can use, which is freely available. So then, with this information, I would like to share as a good thing about our government medical college setup, or the government of Kerala's initiative for newborn screening. That means this is a preventive aspect you are dealing with. That is, it is called Shalabam scheme. It is a comprehensive newborn screening program. I don't know whether you are how much you are aware of it. It is about screening for birth defects, or a functional birth defect like a vision and hearing, the neurodevelopmental defects, pulse oximetry, which gives a clue for a cyanotic heart disease, then the metabolic screening after 48 hours for metabolic abnormalities like inborn errors of metabolism. Here, actually, we have 5 diseases screened under these. That is, we take heel prick sample, we give it in the filter paper, send to the lab, and then we get 5 diseases screened. It is galactosemia, G6PD deficiency, then your this biotinidase deficiency, then congenital hyperthyroidism, and congenital adrenal hyperplasia. So these 5 diseases we have screening, and this is the sample chart where the attendant write all the details of the baby, and you can see, I think you can see this visible birth defects, pulse oximetry, right hand, foot, then autoacoustic emission, testing OAE, inborn errors of metabolism, and the remarks and name and signature of the staff. So that's a really good initiative, and because of this, I can proudly say that so many babies are saved, and this whoever is detected to have heart disease at birth is registered under Hridyam scheme, and they are even getting operated free of cost anywhere in Kerala. So this is one such this chart given to the health worker. It contains mostly, this is really a good screening effort for a visible birth defect. It said visible birth, whatever it's seen. So head and spine, then ears, mouths and lips, abdomen and anus, genitalia, urinary tract, limbs, upper and lower limbs. See, one more is added: chromosomal Down syndrome. And it is written, see, face, upward slanting eyes, fold on the inner corner of the eye, epicanthus, flat nose, small ear, small mouth, excess skin at the nape of neck, palm, single crease, foot, increased gap between first and second. It's with figures, with pictures. They have shown this, and it's a wonderful effort from the health workers side, and it is getting screened. It's meticulously done in our Shalabam clinic. I just wanted to share with you. That's all. I think now it's clear for you, and if anything to discuss, we'll move forward. That finishes my presentation. Thank you.
Thank you, ma'am. Delegates can now post your doubts in the chat box or raise your hand and ask the question directly.
I think I saw one question from Aishwarya P.
Yeah, yes, ma'am.
I think it just moved. Could someone read that question?
Yes, ma'am.
Yourself?
Yes, ma'am. Can dysmorphism occur in autoimmune diseases in children?
Okay. So from this, what you meant? Which autoimmune disease did you suspect, or which autoimmune disease? Like anything you can say. Then I can say more about it. That's why, in which disease or something like that, you can say. Hello?
Aishwarya, if we can unmute.
SLE. Yeah, okay. In SLE. Yeah, SLE, actually systemic lupus erythematosus, it has got a criteria for diagnosis. That means 4 out of 11 criteria you can diagnose. And out of that, mostly in face, there is the characteristic butterfly rash. Then joints nor deformities as such. So as such, you cannot take it as dysmorphism. That is what I can say. You cannot take it as dysmorphism. That means abnormal shape or size like that you cannot. And also that it is a form of an acquired disease, right? It comes a little late and it doesn't fit to your the four patterns of defects that results in dysmorphism. That is the ones which I said initially: malformation, disruption, deformation, and dysplasia. Okay, so these are the four kinds of alterations in your development which can produce a dysmorphism. So out of this SLE is an acquired kind of disease. That's over time the patient is having some problem with the immune function, and body identifies it as foreign or abnormal, then body fights with its own tissues. That is the problem in SLE. So I cannot say it is obviously a dysmorphism, but maybe the reason why you ask, is it because of that advanced state, some edema, some difference in the appearance or something? Is it that? Or have you seen any case or you suspected it that way?
Ma'am, it was just a doubt. Due to my
Okay.
curiosity, I just asked, ma'am.
Pardon? Hello? It's okay, good. Aishwarya, it's okay, good. But are you convinced with my answer? Okay, good. Okay. I think one more doubt I saw, something about the handles.
Yes, Miss. Do systemic pathologies unrelated to genetic conditions contribute to the development of dysmorphism? If so, which is the most common among them?
No. Could you please repeat that? Actually, I cannot see that in my...
Do
Which disorder?
Do systemic pathologies unrelated to genetic conditions
Okay.
contribute to the development of dysmorphism? If so, which is the most commonest among them?
You mean systemic pathology means you mean abnormalities in system?
Yes.
Abnormalities in system, isn't it?
Yes.
Okay. For example,
like
yeah.
like torch infections or something else other than the genetic cause can lead to dysmorphism.
Yes, yeah, obviously, I told in the first slide itself, no. The dysmorphisms, one of the causes is a maternal infections, because then the child will appear different. The microcephaly, see, that is again an alteration in the morphology. It's an abnormality in the shape or structure. But the thing is, it is non-genetic, that's all. Obviously, the torch infection with microcephaly, you will find the child as dysmorphic only. From the first sight, you will take it as dysmorphism only. Yes, you will consider
any systemic disease in the mother can lead to dysmorphism.
not disease. I told about teratogens, right? Valproate. There's anti-epileptic drugs. Then infections in the mother, fetal varicella, that can result in limb defects, skin lesions, cicatricial skin lesions, like that. So that conditions or really maternal conditions can result in dysmorphism. So dysmorphism means something which is causing an insult to the child and causing its development in a aberrant manner, aberrant way. So where that occurs, that is presented in four different ways: malformation, deformation, disruption, and dysplasia. Like that. Just remember like that. These are the four different types where these insults happen and consequences occur from that. So just as in case of malformation, see, you get congenital cardiac disease, deformation like in clubfoot, and disruption in amniotic band sequence, and dysplasia in like achondroplasia, like that. So just I think I think if you learn with that example, then you will understand more about this. Is it clear to you?
Yes, ma'am. Yes, ma'am.
Okay.
Thank you.
Ma'am, here is another question.
Yeah.
How can we handle cases where the genetic cause of dysmorphism remain undetermined after testing?
Okay, good. That's a good question. Actually, that's related to the testing part. Because I think the question is like this. We have suspected a condition and we have ordered a test, but the test became negative, right? Is it
Yes,
that?
ma'am.
Okay.
Yes, ma'am.
Okay, that's good. So that means that depends on that's actually a different situation. Most of the cases, for example, if you suspect a Down syndrome, then you are doing karyotyping, usually you won't miss unless it is mosaic Down. That is one example. This is what I wanted to explain now. That is, if it is mosaic Down, you can miss in a normal karyotyping. That is, karyotyping means you are seeing about 20 metaphases of the cell. Mosaic means what? Only few cells will be having problem, few cells will be normal. So that's a pattern of two different cells in the circulation itself. So if you are seeing more of abnormal cells only, you will be able to pick up that mosaicism. So sometimes that is why to pick up mosaicism, you need 100 metaphases, ideally, but that's practically not possible for the human to check 100 metaphases. But on an average, we check 20 metaphases. So if you suspect mosaicism, definitely you will tell the lab to check more metaphases, or else you have got other modes of testing. Other than karyotyping, you can do a QF-PCR. There you can detect, or if you do a FISH, you can detect, isn't it? So this negative testing, that's a different thing. The point I want to give stress here is that you shouldn't go wrong with your diagnosis from the clinical side. That is what. That is, a clinical diagnosis depends on a good history and examination. Still, it holds good and it's above all. So, if you are sure of that, usually there is no chance of getting an ambiguity in test reports. But if it is so, then you will have to visit again. You will have to go back to the patient again. You have to go in search of more findings or some more investigations, which is helping you in specific diagnosis like that. That's what that's what I can say. Is it clear to you?
Yes, ma'am. Thank you.
Okay.
And there is another question.
Okay.
How to differentiate a dysmorphism in a child with non-syndromic intellectual disability?
One second. I have to connect it to the charger. Okay, please.
Okay, miss.
Could you please repeat that question?
Yes. How to differentiate a dysmorphism in a child with non-syndromic intellectual disability?
Okay, non-syndromic intellectual disability. You mean autism spectrum disorders like that?
No, ma'am. In some cases, there in which intellectual disability appears isolated. With
Hello?
no, hello.
There are some disturbances in your voice. Hello?
Reshma, can
Hello,
you
ma'am.
be a bit more louder?
Hello, ma'am. Am I
Yeah,
audible?
now
Yeah.
it's clear. Yeah, go on.
Ma'am, I'm asking that in some cases, intellectual disability appear isolated without evidence of any other syndromes.
Oh,
Isolated intellectual disability
Now I
only.
got.
Then
Now I
how
got.
can
Yeah.
we differentiate?
Now I got. That is, for example, I have listed few of the syndromes, right, with intellectual disability. And you are talking about non-syndromic, something which is not like this, right? Only intellectual disability. So actually, that's a very broad area. It's not like a small area what we observe. Intellectual disability is non-syndromic. Do they have a genetic cause? That's again very, very different. Approach is same from history if you are getting any clues, from physical examination if you are getting any clues. But usually, if you don't get any clues, then as of now, as per the latest recommendations of American College of Medical Genetics, you can go on to a microarray testing for such cases where you don't find a proper syndromic diagnosis, isn't it? So that is what you can. That's usually it will detect some micro deletion or some defects at the gene level, but still some idiopathic cases are also there. A certain percentage of idiopathic cases are also there. That means whichever you do, however you do the investigations, you won't end anywhere. You won't get an answer. So that is still getting solved.
Thank you, ma'am.
Okay.
Thank you, ma'am. Here is another question. Whether we could prevent fetal valporate syndrome?
Yeah, that is, you have to stop valproate and go for other alternate medications.
Yeah, Miss. Thank you. Miss, here is another question. Uh, Please give an idea on maternal medication intake during pregnancy and dysmorphism in children.
Maternal medication. Hello?
Yes, yes, Miss.
Maternal medication. One we told, no, anti-epileptic drugs. Most of the anti-epileptic drugs like valproate, phenytoin, that is fetal Hyden-Doyle syndrome. So they'll be having so many of the malformations and this cardiac defects, cardiac congenital heart diseases. Then retinoic acid is one such culprit in producing malformations in fetus. Then your warfarin is another that will cause cartilage abnormalities, dysmorphisms like that. So actually, it's a long list. I cannot list one by one now, but these are few examples. That effect of teratogens, that there is a separate topic on that effect of teratogens. If you go and refer, you can find more in the list. So many, 2-3 pages in Nelson.
Thank you, ma'am. Ma'am, one more question.
Yeah.
Any role of whole genome sequencing in diagnosing dysmorphism and when to do it?
Okay, I think actually I didn't go into detail on that topic because we are having a separate class on that. But I can answer this question. You are asking about whole genome sequencing, right? It is not whole
Yes.
exome, it is whole genome.
Yeah.
Yeah. Whole genome sequencing is not popularly done, first of all. It is mostly on research basis because it's very costly because you are seeing a whole part of genome. So that we don't popularly do. We don't do it commonly. What we do is whole exome sequencing. Exome means the coding portion only, isn't it? So the yield of the yield of whole exome sequencing to detect dysmorphism is again depends on the clinical condition of the child. For that, that's the importance is, for example, a child is having this some Marfan syndrome. Okay, so you know that FBN gene mutation is the problem, and if you have clear cut for the clinical confirmation of diagnosis of Marfan syndrome, it is a multisystem. So you have involvement of the skeleton, you have involvement of the heart, then eyes, there is subluxation of lens. So you suspect a Marfan syndrome, and you are doing this thing, this FBN gene testing by a whole exome sequencing, you may get it. But there are many disorders called Marfanoid syndromes. That is, they are called Marfanoid syndromes because they will be having this tall stature, arachnodactyly, everything, but they are not this FBN mutation. So these Marfanoid syndromes, you don't know, there are so many genes for them. So how will you point out that this is due to this gene? So if you can point out that, or you're sure that this is due to this gene, Okay, so then you can order. So that is what is important. So I think for the last 3 months, I can say I have seen about 5 to 6 cases of Marfanoid syndromes, that is Marfan-like. So when we evaluate, it gets out of the scene. Yesterday also, I've seen one patient. He just has arachnodactyly and hyperlaxity, and he was referred as Marfanoid. When I examined, he didn't have tall stature. So he was not tall in stature. So no arm span high arm span more than height like that. So he was not fitting into all the features of Marfanoid. So we have very well put him on further evaluation of eyes, heart, like that. So I'll review that patient again. Then I'll talk to them. So if it fits to Marfan, then I'll tell them, okay, we'll do that test, because it's costing around 10 to 15,000. So you have to give an assurance to the patient that I'll find some result from this test. Otherwise, how can you order for such a costly test? You should get some. They should get some benefit, right? So if you're sure about that diagnosis, you'll go for the whole exome sequencing. If not, then you will again reevaluate the patient. Otherwise, you can talk to them. Sometimes if you blindly go for a whole exome sequencing also, you can get a variant. You can sometimes get a variant. There are chances of getting variant. So in such cases, what you do is you can talk to them. Okay, we'll do this test, but we are not sure that whether we'll catch up this particular variant. But this is the only test available before me. So if you are willing, okay, we can do. Okay, so like that, so that's a difficult area. When you go to the testing, it's actually a very difficult area, the part of counseling, everything, interpretation. So I think for Marfan and those cases with dysmorphism, should we go to NGS or whole exome sequencing? There is no straight yes to that. Still, I say it depends on the condition.
Thank you, ma'am. Here there is one more question. Which management options are available if congenital hypothyroidism is diagnosed intrauterine?
Of course, thyroxine replacement. Nothing else. Thyroxine replacement, because it's absence of thyroid hormone, right? You have to give thyroid hormone. Immediately check the TFT, do thyroid hormone, give thyroid hormone. That's all.
Thank you, miss. Ma'am, one more question. One child with Cry-Du-Chat syndrome with ASD, now approaching adolescence. Now, how could we future course of monitoring and counseling?
ASD, atrial septal defect? Is it atrial septal defect?
Autism spectrum.
Autism spectrum, yeah, because that happens sometimes when you say ASD first, then we first go to this atrial septal defect. I suspected it the other way. This is actually a 5p deletion syndrome, and it's actually this kind of syndromes. As we all know, there is no cure. Cure means at the gene level, at the level of defect, you cannot revert anything there. So you can only support, or you can do the supportive management. That is why for autistic spectrum disorder, you can give behavioral therapy as well as this drug if required. That's all. So that there is no uniform rule for all the diseases, like all autistic spectrum same. No, nothing like that. It depends on the functional status of the patient also. For example, a person with autistic spectrum disorder, that child is not, you must have seen in this TV shows and all these people coming and I mean, they are good at music, something like that. So that is also again different. So the functional status of patient is very important. So depending on that, you can modify treatment for them, but there is no curable options. That's what I feel as of now.
Hello. Namaste, ma'am.
Yeah, namaste.
Yeah, this was me who asked this question, ma'am. My concern was regarding now the child is approaching the adolescence.
Yeah.
How would be her future reproductive status, and how to counsel the parents regarding that?
Regarding autistic spectrum disorder, you are asking?
Yeah, there is a child with Cry-Du-Chat syndrome who was diagnosed at birth. The child is going to school now, she's almost independent.
What about her? Now the child is 15 years. How much?
Yeah, now she is 13 and a half years.
Okay. And this, what about her intellectual quotient, IQ?
Uh, she is average in the IQ.
Ideally, we have to objectively see the IQ, because then only we can predict, how much disability that child is having, how much it is going to improve. Like that, if you want to predict that, you have to objectively look the IQ, check for the IQ. That is important. And
Yeah. She
regarding
has 7.
reproductive options, let her
Yeah.
enter the puberty first. Then only we can see.
Yeah, like the parents would be apprehensive, no? Like how to, I mean,
Yeah, but you can always say the child is having a genetic disorder. Genetic
Yeah.
disorders are usually like you cannot repair at the defect level. That's how you can talk to them. So once it has occurred, even though it is forever, but you can always modify. So that is why we keep the child under surveillance for evolution, any complications or any aggravating problems like that. So you have to keep that child under your surveillance and always be with them, so they'll understand. Because once it's, as humans, it's very difficult to accept the situation of the child once you have a child with deformity. So it needs multiple sittings. Actually, it's not a one-time procedure. It needs multiple sitting for many sittings to them convince about the condition of the child, as well as the treatment options or the prognosis, like that. Ultimately, you should also help them to improve the quality of life. That is all.
Yes, ma'am. Thank you, ma'am. Do you have any experience like these kids would have, similar kids would have normal pubertal growth?
Actually, one I have seen are small kids so far. I'm
Okay.
also monitoring them.
Okay. Fine, ma'am. I just.
Anyway, that is a good question.
Yeah. Thank you, ma'am.
Okay.
Thank you, ma'am.
Okay.
Here is another question. Does the gradient of dysmorphism tell anything about the prognosis of the condition?
Grading of dysmorphism.
Gradient of the dysmorphism.
Gradient means you meant grade, right?
Yes, ma'am. Yes. The severe.
What do you mean actually? Gradient means the grading, right? How much? See, dysmorphism
Yes,
means
ma'am, yes.
you cannot grade. Okay, what did you mean? It's mild dysmorphism. It's severe like that.
Yes,
Is it
ma'am.
that? Okay. So actually,
You said the
as far as
gestural diagnosis.
dysmorphism is concerned, I will say it is major and minor. That we can say. Major malformations, minor malformations. So if it is major malformations, what did I say? If it is untreated, definitely that will affect the quality of life. The child will go into either chronic morbidity or mortality. That is about major malformations. For example, this hydrocephalus, Dandy-Walker malformation, Arnold-Chiari malformation. All these they will be having chronic morbidity. That is about major malformation. Suppose if it's a minor malformation, like in the case I told about a polydactyly. If you see a polydactyly, you cannot label them as a dysmorphic child, but you should look for any other associated abnormalities in your head to foot examination, as well as you should do a good systemic examination to find out any underlying internal organ abnormality. So then only you can say that this is really a problem or not. Hope it's clear to you.
Yes, ma'am.
Thank you, ma'am. One more question. Do children with mosaic Down typically display physical dysmorphism and other features as opposed to other types of Downs?
Okay, that's also a good and very interesting question actually. As opposed to your typical free trisomy, children with mosaic down are said to have minimal features. I mean, not all the florid features, but minimal features. The reason is that depends on the proportion of cells having mosaicism. That means having abnormality. Mosaicism means you have two groups of cells in your body. One is normal, 46, for example, if it's a girl child, 46XX, and other group of cells is having 46XX, 47XX plus 21. So that is the group of cells. So if they have got a proportion, for example, they have 70% trisomy 21 cells and 30% normal cells, what will be that? More of features will be expressed. Whereas they have got a less proportion of abnormal cells and more of this normal cells, less of features. But definitely they won't be looking perfectly normal. I mean, even in mosaic, there are no chances of missing. They'll be having subtle features which will make you think of a suspicion of Down syndrome. Maybe not in newborn period, but at least in early infancy. That's my experience.
Thank you, ma'am. I think we are here to the end of Q&A session. Thank you so much, ma'am, for that truly insightful and engaging presentation on how to approach a child with dysmorphism, and your expertise and your deep understanding of how undoubtedly provided us with valuable knowledge. We are grateful for the time and effort you put into the sharing your experience with us today. Thank you, ma'am.
Thank you.
A big thanks from us, ma'am. Your session was just incredible.
Thank you.
And we actually loved learning from you and hearing your valuable insights. And the time you spent for us, almost 2 hours you had spared for us. And we are actually very thankful.
Yes, I was also happy to teach you. I mean, hope it was useful to you.
Sure, ma'am.
So we'll meet again.
Yeah, we'll eagerly waiting for your next session, ma'am.
Okay, fine.
Thank you.
Yes. Okay, bye. Good night.
Right.
Thank you, delegates. See you tomorrow.